Good evening, everybody. My name is Stephen Villano, and I am the director of the Center for Public Service and Community Research. My office is that glass office upstairs. And welcome to Vital Voices. This is our fourth Vital Voices session this semester. Vital Voices is it was designed to be a very casual place where you guys could come and hear people who are currently practicing in the field, people whose work is interdisciplinary. It's criminal justice, it touches upon education, it touches upon social work, all in one. And we wanted to bring you guys, the students, people who are presently working in the fields, for them to tell you how their work is, what they're doing, the import of what they're doing, and how their work meshes with those other fields. So we have a very distinguished guest tonight, and I am not going to do the introduction because our own soon-to-be Dr. Angie Goins is going to be out. Let's give her a hand. Come on. Woo! So our own soon-to-be Dr. Goins is going to introduce our guest to you. Angie?
Thank you, Stephen. Thank you all for being here. How exciting. I can't even tell you how much it means to me to see my students here, connecting in my present to someone very special to me from my past, which is Dr. Carmel Dyer, who I've known over 20 years. We don't have a lot of people we know in our lives for over 20 years. Usually they fall to the wayside, or you have a falling out, or something happens, they move away. But I've been very fortunate to have Dr. Dyer not only as my mentor, as a fellow colleague, doing geriatric practice here in the great city of Houston. She holds a very special place in my heart for several reasons. I met her when I started at Adult Protective Services over 20 years ago. She really revolutionized how Adult Protective Services here in Harris County does casework. There was a time when I was a young investigator, that was a long time ago, where we had one doctor that we contracted with and one psychiatrist that we contracted with, and that's all we had for all the people of Houston 20 years ago. Well, through her efforts, through her vision, she came up with this idea of having the Texas Elder Mistreatment Team, which goes into the elderly's homes and has a whole team. It has nurses, it has social workers. It brings the doctor to the elderly's homes. This was revolutionary back in the mid-90s when I started in APS. And because of those teams that she created through the Team Institute, they saved many lives that I saw over the years. They saved my client actually was the first team patient, and Dr. Dyer was out there with me in horrible conditions with a man who, if it wasn't for her, he would have died that day. And so she has saved lives. I'm going to tell you a little bit about, but most importantly, she's my father's geriatrician. And if you don't know what a geriatrician is, it's a very special doctor that works with older adults. And believe me, I do home health on the side, and I'm constantly telling family members, have they seen a geriatrician? And they're like, no, what is that? I said, that is a physician who is trained, who knows about the body of an aging person. That's who you want to come and talk to your loved one. That's who you want to take your loved one to if they need medical help. And so she loves my dad. My dad has Alzheimer's. He's 90 years old. He doesn't remember some of us in his family, but when Dr. Dyer comes in the room, his face lights up. And she's been seeing him for probably about 15 of those 20 years. But I want to share with you the special lady that we have speaking to you tonight. She has practiced geriatric medicine for over 20 years as a clinician, a researcher, educator, and administrator. She's one of the leading geriatrician physicians in Houston. She holds the Roy M. and Phyllis Guff Huffington Chair in Gerontology, the Vincent F. and Nancy P. Guinan Distinguished Chair, and she established the UT Consortium on Aging. As of last year, she served as the Chief of Staff at LBJ Hospital. While on faculty at Baylor College of Medicine, she founded the Geriatrics Program at Harris Health. So you are familiar with Harris Health? The geriatric program that's here today is because of Dr. Dyer. Like I said, she created the Team Institute, the first medical school state protective service intervention team in the country. When I was in APS, like I said, she revolutionized the way we did our casework. At UT, where she's currently faculty, she founded the Division of Geriatric and Palliative Medicine. Her research and publications have been extensive and are in the areas of elder mistreatment, interprofessional geriatric teens. In 2005, she was a delegate to the White House Conference on Aging and has provided very powerful testimony to the U.S. Senate for vulnerable adults in Washington, D.C. She's also been vital to the development of the Senior Justice Assessment Center, which just opened up this year, which is one of the first centers of its kind in the country. Now there is a center if an elderly person is being abused, neglected, or exploited. They can now get a comprehensive assessment where Sheriff's Department gets involved, Houston Police Department, the DA's office, the Team Institute, physicians. It's a very interdisciplinary group, and it's kind of the same that they have for the Chimney Rock location for the Child Assessment Center. We now have one in Houston, Texas, and it's the first of its kind. So all of this would not be possible for the lady sitting here who's about to speak to you. So please give a warm Houston welcome from UofHD for Dr. Carmel Dyer.
Is this on? Can you hear me? Am I on? Well, thank you, everybody. I'm so happy to be here. I know that some of you may have studied all day or you were working with it, but I am just delighted to see all of you here. Angie, you know, nobody can do any of this sort of work by themselves. If it wasn't for the interprofessional work that was done, we wouldn't have gotten off the ground, because nobody, when we would write grants, they said, Adult Protective Services won't work with you doctors, and you proved them wrong. And so a lot of good things come from us working on interdisciplinary teams. But let me begin. I wonder how many of you are like me, and in the level of your training where you thought, I'm going to work with children. I thought I was going to be a pediatrician. I thought it just would be great to work with kids, and it is great to work with kids. But something changed my mind. I went to work in a nursing home. In college, because there was no room for me at the hospital. So you needed to have some medical experience to get into the medical school, and so I went to the hospital. They said no, but a nurse at the nursing home opened up the doors to me, and I thought, this is the best thing I've ever seen. And that just set my career on a different course. Now, some of you are already headed for gerontology, but I hope you all will sort of open your minds a little bit tonight on what might be possible in the field of gerontology and geriatrics. And geriatrics is the medicine of aging. Gerontology is the study of it. So look what we are facing in Houston. There's about 600,000 people now over the age of 65. 10,000 people are going to turning 65 every day in this country, and look at what Houston is going to look like by 2050. All us baby boomers, we're going to move into that over 65 group, and there's going to be a lot of work for everybody here, and a lot of things to do, and a lot of ways to contribute. So, 73, what is 73? 73 was the age Ronald Reagan was when he started his second presidential term. 75, what's 75? 75 was the age Nelson Mandela became president of South Africa. What's 76? Grandma Moses gave up embroidery for painting. 77, the age Winston Churchill became prime minister. Look at what people are able to do in their old age. It's amazing. So here's what I thought we'd do today. Talk about the healthcare workforce needs. I have an activity in each section. Criminal and social justice workforce needs. And then end with population needs, and leave time for your questions. So, first activity. I wonder if you all have a person in your life, person or persons that are older, that have really impacted you. Maybe grandparents, co-worker, neighbor, parent. Is there anybody who would like to share something about somebody in their life who's older that had a big impact on them? I mean, you have that. Yes, you'd like to share? Yes.
My son was being bullied in high school, and there was a mentorship program where elderly veterans would come in and, thank you, elderly veterans would come in and work with these children that were being bullied. And so this started when my son was in 6th grade, and this gentleman stayed with him until he graduated high school, and to this day is very close to my son, and I don't know that my son would have made it without this retired veteran.
That's a wonderful story. That is terrific. Thank you for sharing. You had a story.
My grandmother actually got me interested in social work and gerontology. I took care of her as she got older. She's now 89, I believe, and she has dementia. And so that's where I started and had my foot in the door as I went into home health care. And she's practically raised me. So the impact of her, going through this and losing, parts of her mind is just, it's an incredible experience to watch. It's saddening, but like the way that they deal with it is just something that you just don't see every day.
So would you say that she gave to you all of your life, and now you have an opportunity
To give back.
to give back? Anyone else want to share a story? Well, as you go through, and as we're talking, think about that person if you have that, if there's somebody in your life that has had that impact. Well, I already talked to you about how many baby boomers are turning 60. It's actually 65 every day. But did you have any idea that this many people were in our hospitals today? I mean, Texas Medical Center is the largest medical center in the world, and that just isn't something we say here in Texas. It's really true. 40% of hospitalized patients are over the age of 65. 40% of all surgical patients are over the age of 65. And if you take a look at elective surgery like knee joint replacements, that number approaches 60% of people are over the age of 65. Look at this, Medicare admissions. Now we know Medicare is a big, expensive program, a huge part of our gross domestic product. Almost up to 20% of the admissions are for adverse medication reactions. I mean, that means, and a certain percentage of that is avoidable. Oh yes, and seniors are the highest users of the emergency room. They take more time, they're more likely to be admitted, but there they are. Well, moreover, 26% of all physician office visits are by the elderly. A third of all prescriptions written in this country, elderly people. And 82% of older people have at least one chronic disease, hypertension, arthritis, and heart disease. And 2/3 will need some form of long-term care in their lifetime. Now, to you, looking at what this means for the workforce is one thing. People in my age group, baby boomers, thinking, hey, that's us. That's us. I mean, right? It's great if you're very active and you do what you want up until the time that you die and you fall asleep and that's it, you go to heaven. But that's not what happens to most people. Most of us are going to have a period of disability in our life. And so then we may interact with the criminal justice system, clearly going to need social work. We're going to look, if hypertension, arthritis, and heart disease are the biggest problems here. And I can tell you, the older you get, you have to add hearing problems and visual problems. And so there's a lot of opportunity for public service in this population. Well, there just ain't enough of us to do the job. 29 of 38 states surveyed said there's a shortage of direct care workers, and it's serious or very serious. So direct care workers are not administrators, not that hospital administrators and other administrators aren't important, but these are the people who actually place their hands on the seniors and work with them. Huge shortage. I spoke today to a group of people at Tony's restaurant, and it was about, I don't know, 50 people there. I asked them, and they were baby boomers, you know, and plus, I asked them how many of those individuals had to arrange care for their family members. About 60% of the group raised their hand. And it is not easy to do this. So there's a big shortage of geriatricians. I'm glad, Angie, you're telling people, see a geriatrician, but we don't have the numbers. We do not have the numbers. So if you Google geriatrician, board certified geriatrician in Houston, how many do you think you come up with? In a city, what do we have? 6 million people right in our area in Harris County? How many board certified geriatricians? 100? 35. 35. And some of those, their boards lapsed. But, no, maybe not. There's just not the numbers we need. We are in Houston, we're well below the national average. Well below the national average. And so, 2025, there's going to be a huge shortage overall of all physicians. So here's the map. All you need to know is Texas is there in purple, below the national mean for board-certified geriatricians. But let me ask you, maybe some of you have children or nieces or nephews. How many of you would send them to a doctor or a nurse practitioner that wasn't trained in pediatric medicine? You wouldn't do it. But what do we think about sending our loved ones to doctors not trained in geriatric medicine? You know why the direct care workers are so important, social workers, etc., because you're dealing with physicians who don't have the training in geriatric medicine. If you're an internal medicine doctor, how much training do you think you get? It's a 3-year residency. How much of that do you think is devoted to geriatric medicine?
6 weeks.
6 weeks? That's a little high. 4 weeks. Some of them take vacation during that rotation as well. If you're a family physician, it's 6 weeks. In Great Britain, geriatrics is its own specialty. Here it's not. This is geriatric psychiatrists, and numbers are even worse. The Institute of Medicine published a report entitled Retooling for an Aging America, Building the Healthcare Workforce. And this was by NBC Nightly News, just a warning about the national medical system. And the LA Times called it crisis-level shortages in healthcare workers with serious gaps in training. But I will show you a little later, it ain't just the physicians that are needed. It's everybody on the healthcare team. Well, anyway, so why do we even need that special focus? What's so different about older people? Why do you need to have that special training, right? They're going to hospitals, they're being seen by hospitalists, etc. Why is that training important? Well, look what's happening. Surgery at the end of life, about 1/3 of 1.8 million Medicare recipients that died in 2008 had surgery the year before their deaths. 30%. So how do we interpret that? There's 2 interpretations. Well, I guess there's 3. One, oh well, it was by chance. That's one interpretation. The second one is that they may not have needed the surgery. That they had this surgery, but yet they were in the last days of their life. The third is that the surgery could have resulted or led to their death. Because it was over-aggressive, because they had complications from the procedure. And as this doctor here points out, These surgeries didn't help people's lives. They just got it. The hospital's a problem. I don't know if any of you all will maybe consider a social work in the hospital. But the hospital's a very dangerous place for older people, and sometimes the only advocate is a social worker. So, in this one, it's a landmark study. It's from 1993, and it's still cited today. 31% of hospitalized older patients lose the ability to perform an activity of daily living. And I don't mean like writing checks or ballroom dancing. I mean they can't walk at the end. They have trouble toileting themselves. 40% of these adults remained impaired 3 months later, and 40% had IADL, which means that they did have trouble writing checks, driving after a hospital stay. And aren't you supposed to get better in the hospital? People get worse. Older people lose strength at the rate of 5% a day. Bone resorption is 50 times the usual rate. They get pressure ulcers, and 25 to 30% are malnourished while they're in the hospital. But who's advocating for people in these situations? What's happening? They're going through a system that's designed for 50-year-olds. Now, nothing wrong with 50-year-olds, and that's good care for them, but it's as if we went into a store to buy clothes and everything was the same size. You went in, there's one size fits all no matter what you picked up. And it was expensive, too. And that's what this health care is like today. So do geriatric teams make a difference? The answer is yes. So the Cochrane Group, have any of you heard of the Cochrane Group before? You have, some of you have heard. So what they do is they take difficult questions and they review the world's literature on it and come up with an answer. So this is not funded by the American Geriatric Society or the Gerontologic Society of America. This is an independent group. And what they did was they took 22 randomized controlled trials. So that's the highest standard for a trial, randomized and controlled. And it included 10,000 patients. And this is 20 years of literature. And what they found is if you were cared for by a geriatric team, and that CGA is Comprehensive Geriatric Assessment, and that's where a team comes in, nurses, social workers, therapists, doctors, and they give you a good assessment. You were more likely to be alive and living in your own home at 6 and 12 months. You were less likely to go to a nursing home, be institutionalized. You had better cognition, and you had no increased cost to the hospital and obvious decreased cost to society. For some reason, this is not enough evidence for people. But this is the strongest evidence that we could possibly have. So take a look at this list and think about your careers. Are there things that you could help along this list of what geriatric patients need in the hospital? Medication management. Sometimes the social worker is the only one that can advocate for, is this the right medicine? Why are you putting somebody on this medicine? I know Angie did that for her patients. Cognitive behavioral disorders like dementia, depression, self-care capacity. Big issue for the criminal justice system as well as the healthcare system. When we've had when perpetrators come to us, they'll say, well, and I'll never forget, they brought us somebody who, an elderly man, he shot his son. And they brought him to us immediately after the event for us to determine, did he know he was shooting his son or was he not well? Because that determined whether he's going to go to jail or go to the hospital. We determined he was not well. Falls, balance, gait disorders, healthcare planning and promotion, disease presents differently in older people, palliative care, that's the care you give when you're not trying to cure somebody, but you're trying to improve their quality of life. And then there are teams that work just on hospital care for elders. So I want to give you a story of this patient. This is Mrs. B. She is 89 years old. So prior to this picture being taken, she was completely independent, living alone at home. She was on 6 or 7 church groups. She had an event at the end of April. But before that, she got all her taxes into the tax man, all the paperwork, etc. Then she had a massive stroke. Massive. She looks fine there. She's got makeup. She had a massive stroke and became completely dependent. She's in assisted living now. That's a hospital bed. That's her walker. She's in a wheelchair. And so some of the things that happened to her along the way were, right after the stroke, the doctors thought she had an artery inflammation, and so they did an inpatient procedure in the hospital with general anesthetic in a patient who just had a stroke, when that procedure is normally done on an outpatient basis with local anesthesia. She was determined to have uterine cancer, and the doctor, during the same hospitalization, wanted to send her to the operating room. Very frail, the patient was frail, wanted to send her to the operating room. That operation would have killed her. Would have killed, no doubt about it, would have killed her. She had a couple of more strokes after that. She got admitted to the hospital, and the doctors said they would give her large volumes of fluid. They wouldn't do physical therapy, so they put her in one hospitalization, and so this was the physical therapy. Walked her out of the bed, around to the other side of the bed, physical therapy done for the day. She needs to go to rehab skilled nursing unit rather than back to her home at the assisted living. So the family eventually decided, she had a stroke right in front of them, and she wasn't going back to the hospital. And now she's on hospice care, and look at her. It's been weeks and weeks since she had a stroke. She's enjoying life. She needed a little help to put her makeup on. She has 24-hour care, but at least her quality of life is better. And I will tell you that her daughter is a PA, another daughter is a nurse, her son is a social worker, and her daughter, and one daughter who's a geriatrician. And yet all these things happen to her. All of these things happen. And we're working against the medical system. And so all of you here, we all have to think of ways that we can be advocates for this sort of thing. By the way, this is my mother. That's my mother. I did not think that I would be a caregiver. Well, I thought, oh, she'll have a hip fracture. I had some idea in my mind what would happen to her. Never thought this would be like this, and that we would be on the caregiving end. And boy, am I grateful for my family. But what do you do if you don't have that complement of healthcare professionals to help you? Because she's in Florida, and there ain't geriatric care there either. So that's a lesson that we never know when we might be in this situation. Maybe some of you are already caring for people with dementia, but she's got severe vascular dementia now. So who's the team that we need? You need doctors, nurses, social workers, psychologists, pharmacists. But look at this, dentists, physical therapists, chiropractors, anybody can be on this team because older people need advocates. And the team is going to look at all of these things, right? What are the medical issues? What are the psychological issues? It's not like treating a 50-year-old, because a 50-year-old determines where they live. They make those choices. Some elders can't make that choice. Economic issues and treatments, not everybody can afford to have assisted living or to have 24-hour care. Well, how do we help those individuals? Most of my career I worked in the hospital district. And families stepped up and did what needed to be done, but we have to marshal the resources in the community so that people can access this. That I can tell you that, I know a little bit of social workers. I've been privileged to work with so many and have geriatric training, but do you think physicians get any social work training in it? Zip. Zero. They rely on all of you to do that. They need living conditions and treatments. People ask me all the time, what's that place like? I want to move mother to the Buckingham. Somebody has to have been there, looked at that, and give advice to family members. Look at this. I said it's not just geriatricians. Look at these direct care workers. It's one of the fastest growing areas around. Can you provide direct care? And that's been a lot of a source of work for immigrants to this country, is to become direct care workers. They may have had that experience in their own country, and so they provide a very valuable service. Anyway, we're going to need huge numbers, and so how many of you, and here's what geriatric nurse practitioners do. It's the same thing that the physicians do, work with the family. The geriatrician looks at medicines, is a mentor, and looks at the medical issues. What do gerontologic social workers do? They look at the physical. They have to understand the medical history, right? You guys keep me honest, am I right? Right? You have to look at how the patient is, what's the behavior. Psychological. A lot of time, in a 10-minute doctor's visit, you ain't getting this part. What's the psychology? How is the patient feeling? What's their attitude? What is their normal personality like? What's their self-image? Social. What role do they play in the community? How do we help them with that? What's the financial issues they have to deal with? So what does nursing home cost a month now? $8,000. Can you imagine? Assisted living, same thing. Same thing. It's costing people tens of thousands, well, hundreds of thousands a year sometime for this sort of care. How about their cultural values? Right? You know, there are people who would come in and foist end-of-life issues on individuals. I don't know if you've all ever seen some of this, pushing the hospice. Well, maybe that is the right thing, and maybe it's not. But we have to take the individual's cultural, religious, personal background into account when we look at these things. The environment, and then also, what about the spiritual? I understand you had a chaplain come speak to you. This is something we never go near as physicians. But it would be so important, it would be a very important way for some individuals to recruit what's important to them and have them use it for their own benefit and their own healing. The Institute of Medicine is talking about making all this certification. So now, there's a social work certification in gerontology, correct? But that's not required anywhere, right? You can work in a nursing home, you don't have to have that. There's certification in geriatrics. No one's required to have that. You could be a medical director of a nursing facility. Do you need anything to be able to do that? Just your MD or DO degree, that's all you need. Same thing with nurse practitioners. They kind of did away with some of the gerontology and just called it adult. We have to move towards, we have expectations for people to have the training needed to do the job. And that's where the Institute of Medicine was trying to go. So if you are, now when you're in your studies, you're entrenched, and if you have the opportunity with the way the population is going to get a certification to have credentials in gerontology, I would do it. You might as well. You're in the middle of all of this. You don't want to have to do it 5 or 10 years from now. I would really, I would think about it, because there's going to be a huge need. Okay. Should we take questions at the end or in the middle of the section?
Wherever it works.
So what do you think? What questions do you have about healthcare roles for all of you in gerontology? Are there questions about that? Yes.
I'm wondering how the things that you're talking about that need to be done, how they can interact with medical right to privacy or thanks. How the implications of right to privacy, HIPAA kinds of things. I see sort of a conflict where the team might say this needs to be done, this is the best course to take, and the patient or the patient's family saying no, or not being able to, having right to privacy, not being able to get through to those issues. I hope that's clear enough.
There's almost two issues. The right to privacy, when you're in the treatment team, there, you have a right to share the information. If I'm treating a patient and another doctor, cardiologist calls up and wants that information, I can share that. So that can be shared. But one thing I didn't put on the slides, and thank you for bringing that up, is that part of the team is also the family and the patient when they're able. And that's why I dwelled a little bit about the social worker and bringing their cultural beliefs in. The team can formulate a plan, but it has to be done with the person's individual interests in there. And if we can bring the patient in, I can tell you, Mrs. B can't participate in those decisions. So we had some discussions with her before, not enough, but we could try to work within that. But getting to find out what somebody's values were, either from them directly or from family members, is very important. No, and none of this can be foisted on somebody. It has to be done with them. But you know what I found? If you explain it properly to somebody, to family members, they understand, and to the patient, why that is. And you know, nothing's all or none. You could try a medicine. It's not a lifelong sentence, you know. Questions about gerontology roles in healthcare? Yes.
I work here in sports and fitness, and I train trainers how to be trainers. And so we have personal trainers coming up, and they always want to train the 20-year-old who, you know, still has all that muscle mass. And I tell them, one, your 20-year-old can't afford you. And two, our elderly population can and they need you. So we're trying to encourage our trainers to step out of that box and realize that there's a future in helping, and we need to help, you know, not necessarily when they're, I mean, definitely when they're 65, but when they're 50 and 48, and when they've lost so much muscle mass, that we can start improving upon that so that they're living longer, they're stable, balanced, they have a lot of things that we start losing early on. So
no, that's a great.
We're trying.
I have so many patients and their children in like their 50s, 60s. Remember, when I talk about the children of my patients, they're like maybe older than me or my age. That the muscle mass starts to decline. They have personal trainers. I think patients, you know, physical therapists are expensive. They're PhD trained. They're, you know, very helpful, very necessary. But the physical trainer to come to your house and keep, because your Medicare benefits run out, and the physical PT has to leave. But the trainer, you can pay for the trainer. You can have somebody. They can work with you. They know you. Besides, after age 50. You start losing muscle mass like this, so you got to maintain. No, that's very important. By the way, exercise, walking, running, is the only thing been known to prevent dementia. It's the only thing. They believe that there's a substance elicited in the bone. You know, as the legs pound the pavement or the, you know, the elliptical or whatever, that's secreted, that enlarges the hippocampus, one of the sections of the brain, and actually that increases in volume and improves your memory. So if you've got a big test coming up, so get out there and it could be just walking works or running, but anyway. Questions about healthcare? One, yes.
What are some ways or tips you would give a social worker to say no to a doctor when they do see that they don't need that surgery? Like, how would you approach the doctor and say, no, this could kill the patient?
You know, the question is, how do you approach this? It ain't that easy, because even doctor to doctor, it's a little bit of a challenge. What I would do is I would speak their language. So what you would have done that the doctor probably didn't do was check the mini mental status or done their cognitive screen. Say, doctor, are the patients depressed? Doctor, do you realize that this patient is severely depressed and makes a 9 on the geriatric depression scale, and that's a risk factor for death? You can say it in a nice way. Say, you know, so I'm concerned about that you're making a stupid choice. No, I'm very concerned about this. And what's the mortality? You can ask questions. Well, what do you think the mortality is when somebody already has depression, or when they have dementia? Or what is the risk factor associated with giving somebody a general anesthetic after they've had a stroke? So you can kind of ask questions, but if you bring data to them, You know, doctor, I noticed that the last time she had surgery, they may not know this, the last time she had surgery, she had a prolonged hospitalization and had 3 weeks stay in the skilled nursing unit. Will this happen again? By asking questions, you may do that. The other thing is you can talk to the family and say, how about we get a second opinion? Or call for a geriatric consult in the hospital. In St. Luke's you can get one, in Methodist you can get one, in Memorial Hermann, in the Med Center you can get them. Not at all of them, but second opinion, I mean, nobody should be opposed to that. Those are some tips. Good question. It ain't easy. You just have to learn, you know. It's trial and error.
Can I address, I'm sorry, go ahead. I just wanted to address her thing real quick.
My dad, who's in his 80s, was prescribed fentanyl patches by one of his doctors, by his primary care physician. And my sister, I'm similar to you. My sister's a nurse. Her husband's a PA. It goes on and on. And I was texting my sister, and she said, "Oh my God, no." You know, she couldn't say it enough. And so, after trying to get the fentanyl patches from a drugstore, which I could not do without getting a lot of questions and telling me I had to wait 3 months and things like that, I said, you know, I'm going to get a second opinion. And I went to his cardiologist and I said, you know, his primary care physician is prescribing him fentanyl. And they were very polite, but they asked who the doctor was, and then they said, you know, we have a list of other doctors that your father can see. And they didn't disrespect the other doctor, but they made sure this was a doctor, the cardiologist was somebody my dad trusted, and they made sure that they recommended somebody to me immediately to let me know, don't go back to this doctor. And I felt like that was a really good way for them to sort of deal with it.
Yeah, that's thank you.
Have you noticed, or do you see a need for the future private practice for gerontology for social workers, as a lot of the children of the elderly, not say they want to farm them off, but dual careers and maybe too busy to take care of their family?
Oh, without a doubt. You know, I mean, I've done so much work in the public sector, but the private sector, geriatric care managers, which can be social workers or nurses, it is key. So, you know, when you go to Florida, right, everybody lives somewhere else. All of these parents all migrated from New York and New Jersey. They're there by themselves. And then the geriatric care manager, and we interviewed several groups actually for my mother and hired a care manager for her, but that is an ideal role because you're an advocate for the patient, you're an advocate for the family, your eyes and ears, and so, oh yes, and the reimbursement is good. It's not like the public sector, but I mean, you can't put a price sometimes on, you know, if you're in California and mom is in Houston. That's important. Thank you. That's a great question. Great question. All right, let's move on. Oh yes, one last. Sure. Of course. Of course.
I need to ask you a question. And my mother's 86.
Wow.
And she's been through cancer treatment. Had a stroke, minor, and I guess by default I'm kind of responsible for what's in our best interest. I have other siblings. So my question to you, because of the shortage, and trust me, I didn't know anything about geriatricians. This is all new. So because of the shortage, why would I transfer her from her primary care, which is really internal medicine, to geriatrician when there's a shortage?
So I think that if she's getting good care. Now, when I talk, I'm talking in generalities. I'm talking about most people don't have the training, but there could obviously there are individual physicians who make it their business to know. And if you're comfortable with the care, I don't think there's any reason to change. But if things,
I'm not.
well, if you're not comfortable, then I think you should think about it. Then you know, you need to be able to put your head on that pillow at night and rest comfortably that you're doing everything for your family member. And like I said, if you were okay with the care, no reason to change. If you have questions, the other thing you could do is you could ask for a geriatric consult. So that's what some of the patients do, because the mother or dad has gone to this doctor for years and years, and they don't want to offend them, or they have a relationship. So what we do is we'll do a geriatric consult. We'll send a letter to the doctor saying, here are some geriatric issues. Or we've called them up, and if it's done in a nice way, as you point out, they usually take up you give them the reasons why. Here's this test, here's the results, here's why we say it, here's the literature, here's why Eliquis is better than Xarelto, all of those things. And then, but no, you need to feel comfortable. You need to find a way to feel comfortable.
Can geriatricians be PCPs?
Oh, yeah. Yes, I should have explained that. Geriatricians can be PCPs or consultants, either way. All right. Well, let's move on to elder abuse. Just as like there's tons of geriatric health care that's needed, boy, is there a lot of abuse going on in your neighborhood, in my neighborhood, every day that we may or may not see. The definition from the National Center of Elder Abuse is when you're in a trusting relationship with an older adult and you commit an act of omission or intent to harm or provide discomfort. So, here's an activity to get you thinking about elder abuse. So this is November 2017. So let's say it's November 2018. It's a year from today. And you're responding to a call from a neighbor, elder in distress. When you get there, somebody who looks like they're in the mid-80s is agitated with a bloody face and clothes. The house is very dirty and cluttered in certain rooms. A grandchild emerges from a bedroom stating, Grandma, I fell again. So what I would like you to do is turn to your neighbor in twos or threes and answer these 3 questions. Let's just take about 5 minutes to answer these questions with your neighbors. What are you going to do?
Is the grandchild an adult?
Grandchild's an adult. And this, if you're 80, the grandchild's an adult. Okay. All right, challenge. I mean, this is a case you're going to see. I mean, this is just bread and butter stuff. So, what are your first steps? What do you do? You're called there. What do you do? What's the first step? Yes.
Our team wanted to separate the two parties.
A
Our
good
team
idea.
wanted to separate the two parties.
Good idea. Excellent idea. Good. What else?
Send the medical needs first.
That's right. Is she bleeding a lot? I didn't give you much history, but right. But are the medical needs? Is she dizzy? Is she? That's right. Very good. Yes.
Well, we also said ask questions, see maybe if you remember where they're at, or see if there's probably any hallucinations or dementia going on, or maybe they stumble across something on the phone.
Yeah, ask a few questions. I think that's right. Sometimes, so when I get called into to cases or whatever, I mean, you can go take a whole long history, like some of the doctors do in the emergency room. They're taking this long history from a dementia patient, and they're really giving their dead husband's history, and all of that. No. A few questions. Ma'am, do you know what year it is? I mean, if they think it's 1997, and Bush or Clinton is president, or whatever, is president. Anyway, or McKinley or Eisenhower, you're not going to go further with the questions. You're going to spend your time right in criminal justice. You're going to go elsewhere, figure out where you can get the history. So, do we think this is mistreatment? We do. Some do, some don't. Who thinks this is mistreatment? Raise your hand. Okay. Why?
The fact that the house is very dirty
Okay.
puts the patient or the victim in jeopardy alone. That's enough to make the phone call.
That's enough to have a suspicion. Oh, all right. Who else thinks it's mistreatment? Yes?
The grandchild isn't there to watch over the grandchild isn't there to watch over the grandparent in case, maybe the grandparent had a stroke or has problems remembering. They're not there to, make sure that they're okay if they need anything. If they're if they're in need, they're not there to take care of them. They're somewhere else. So.
Well, think about that. Who made the call? The neighbor. Not the person in the home with the grandma's, got a bloody nose. Right. Who else thinks it's abuse? Yeah, this is a repeat. But you think it might not be,
Well,
right? And I think that we have to consider that too, right?
Well, what I was going to say is one way you can say that it's mistreatment, if the home is cluttered, that means that is an additional hazard for the elderly person. If they possibly have dementia, the clutter could contribute to a fall, or so keeping the home cluttered could be a form of mistreatment because you're not keeping the person safe by keeping the home clear of clutter.
Who else thinks it might not be? Yeah. What do you think? I think that's...
The reason why I don't want you to think I'm running around like a chicken without a head, but the reason why we try to get everybody on the mic is because when these are seen online, they can't hear people's questions and comments. So that's why we try to get everyone on the mic.
It may just be a matter of everybody being overwhelmed. And, there's a grandchild. You didn't say how old the grandchild. It could be a 5-year-old grandchild and a great-grandparent. And there's somebody out working 2 jobs. They don't have the infrastructure to clean the house. And they're trying. Everybody's trying, but 5-year-old grandchild doesn't know how to clean the house, and the elder in distress can't. So,
I think it's right. I think there's two. That's why we present it this way, because it's not absolutely clear cut. Yes.
Like what she said, but then I thought about it. In that case, wouldn't that still be considered neglect? Because if the neighbor felt that the situation was bad enough for them to call, and then let's say that there is a 5-year-old, then why is it just them 2 in the house, 2 people that have a difficult time taking care of themselves? Also, like someone else said earlier, like if the neighbor decided to call, they must have really felt that was an issue. Like personally, when my neighbors do stuff, my first response isn't to intervene unless I really feel like they really need help. But that was one thing. Also, we all have our times when we just don't clean our house. But if it's cluttered to a point it's very dirty, then let's say it is an older person, that goes with the neglect too. So even if they weren't being abused, that would go with it. But it seems unlikely that she just fell down the stairs.
Yeah, so I think that, the idea of separating the two and getting history, it's really clear. Because these cases, it's never, unless you see them hit and you're coming on a scene, you have to look at all the different things. This neighbor might be in a dispute with the, they mowed the grass on my side, they threw the grass clippings over the other side or something. You never know what could be. But the key is they need to get more history. And so those are the short and long term. What are you going to do right away? What do you want to do right away? Assess. Yes, what did you say? Yeah, so you may want to call 911 or get her to emergency room. That's right. Do an assessment, talk to them. And what do you think some long-term interventions might be? Yeah, and who might we call? Who might we report to at this point?
The parents of the grandchild.
And what agency would we call? APS. Right, because there's probably enough suspicion to call, and they can check, and they're the experts. That's why I tell, doctors are afraid. They're like, oh, I don't know. It didn't meet I didn't see it. I don't have full. If there's suspicion, you call the experts, Adult Protective Service are the experts, and they come in and make the assessment. Our job, unless we're the experts, is to decide. But you're right, not to jump to rash judgments. But very good, very good. You guys did great. Great on that. Yes?
What are the requirements for physicians as far as consulting or reporting to APS like there is for child protective
I'm going to
services?
get to that, but I'll answer right now. The truth is, everyone in the state of Texas is a mandated reporter. So if we see, if our neighbor looks like, that they're, we're supposed to report. Everyone's a mandated reporter. Now, they didn't really prosecute you for that. They could. I think it's a class A misdemeanor now. I think it went up from a C to, I think it's a class A misdemeanor not to report, but they're not going to prosecute, the 80-year-old neighbor next door for not reporting. They're going to come after the health professionals or the physician. And in cases where they have won them in other places in the country, they've gone after the doctors, because doctors generally don't report. Somebody on the healthcare team does it. That's, they don't do that, but you could, and we're all required. So there's physical abuse, right? Intentionally hurting somebody. Are you all familiar with the types of abuse? Have you all had this, or this is some new information, huh? Sexual abuse, you all would figure that what that is. Sexual contact with a patient incapable of giving consent, and it extends to unwanted touching, coerced nudity, or sexually explicit photography. The psychological abuse, infliction of anguish, pain, or distress, verbal assault, humiliation, harassment, infantilization. I have seen this in the office. I mean, it's amazing. I wonder. So, we bring, mother and parent and father and daughter in the room anyway, and then they're yelling at them. And I just have to wonder, what in the world? If that's what they do when other people are listening and watching, what's really happening at home? Financial exploitation. Someone in a trusting relationship uses the resources of elderly persons without consent or for self-gain. Caregiver neglect, and this was considered, yes, question, yes.
I'm sorry.
I'll repeat it, yes.
So if you know someone that is, getting yelled at because she's older and her daughter is taking care of her, should you say something about it? Or do you just stay quiet because the person that is getting abused is trusting you into not saying anything because she's afraid that her daughter might do something?
So that's a very, very good question, a very complex question. The question is, if you see psychological abuse, is the patient relying on you not to report? And so, truthfully, in that case, it's important that an investigation is done. So you would separate the two. You would see, does the parent want, is she concerned? Is your daughter yelling at you? You know what? She just got bad news that she developed breast cancer. And so she's not herself today. And you get that history. Or if she says, I'm so glad you've talked to me about this. I have to go through this every day, and I'm not sure I can take it anymore. Those are two different answers. So you have to get the history. Sometimes it's cultural. I don't know if you've ever, in my house at Christmas with all the Italians, everyone deciding which restaurant you're going to go to is a 30-minute ordeal. Sorry, Dr. Villano, but I'm just telling you, that's the way it is in our family. So, you have to take into account cultural issues and all that. You have to be careful because you don't want to endanger the elder. But reporting is anonymous. You can go online, although that's not anonymous, but you could go online and report it, but generally they don't really find that out. Or you can call up the hotline, it's absolutely anonymous. And APS workers may not, shall not, give your name if you report that. And so if you have a suspicion, maybe it's nothing. Or maybe it's just the tip of the iceberg, what's really going on at home.
And is it normal for the daughter, she gets money monthly, for expenses and stuff like that. Is it normal for the daughter, suppose she gets $700 a month, and that's supposed to last her for the whole month. Is it normal for the daughter to take $600 and just leave her with $100?
No, that's not normal. That the daughter can't use any of she can't use any of the money for herself. The daughter or son cannot do that. If the senior gets 100, the other 600 have to be spent on the senior because that's their money. No, that is against the law. That's a crime. Caregiver neglect. You don't give people what they need or you abandon them. We've had many cases people abandoned in hotels. Elder self-neglect. So this is the most common case reported to Adult Protective Services. Little old individuals, they can't provide for themselves. And so they're in their homes. Nobody really knows. Maybe we all have somebody in our neighborhood where the grass is kind of high, or there's lots of cats running around, and it's a problem, the roof is not repaired, and all of this. And we've seen some things. It's the most common form. What do you think the second most common form is of what I've described? Financial. So, there's no good elder abuse talk without a picture. You know, I thought when we started to do these house calls, Angie came to me. She said, would you do house calls on our patients? I thought we were going to go in the afternoon, and we were going to go sip tea and check blood pressure and all of that. And this was your, yeah. And so this is what we saw, and this is not a bad one. And so we didn't give you a lot of, this is the guy with the eye was missing. Yeah, his eye, he had let cancer erode into his eye, and one of his eye was missing. And so, yeah. So probably, we're estimating about 2 to 10% of older adults are abused. When they do telephone calls where people actually admit it, it's 10%. That's not counting self-neglect. Only 1 in 14 incidents come to the attention of authorities. So in child abuse, 80% of the cases are reported. Big picture, this is some percentages, but 80% of all child abuse cases are reported that occur. In domestic violence, 50%. Elder abuse, only 20% are reported. Just the opposite of child abuse. It's not recognized, it's hidden. People are embarrassed. I let my child do this to me, I let my grandchild do this to me, or I don't even recognize that something's going on. And the numbers are going up because the numbers of older people are going up. Yes?
Well, my grandmother would hit herself, and when we went to a doctor to talk to a doctor about that, they said that a lot of elderly will physically harm themselves as well.
I haven't not seen that many where they hit themselves, but I certainly think that you could be so depressed that that sort of thing might happen. It's serious. Yeah, yeah. Well, I'm sorry to hear that. It's tough. But anyway, as I said, 1 in 5 cases are reported. Well, so what? You have self-neglect, you're abused, that's unfortunate. But, why should people in public service care that much about it? Why should there be policy changes? Well, it leads to functional decline. All your chronic health conditions get worse. Your self-rated health is worse. You experience helplessness, fear, social isolation, stress, decline, and increased visits and hospitalizations. These are the frequent flyers that we talk about in the hospital emergency room. Any of y'all visit any emergency rooms? This is what happens. This is what we see. Oh, yeah, and by the way, it's a risk factor for death. Elder mistreatment, elder self-neglect is a risk factor for death. In the 90s, when we wanted to study this, everybody said, that's not medical. They wouldn't even accept a poster presentation at the American Geriatric Society on elder abuse. They thought, that's not medical, well, it's medical, it's social, it's psychological, it's criminal, it has everything for everybody. And by the way, what do you think, in the state of Texas, we've done the analysis, actually, Dr. Burnett is one of my colleagues and Angie's colleagues, done the analysis. What do you think the most common thing that kills people is? What type of abuse? Caregiver neglect, absolutely. What's the second? Financial, because people get kicked out. They can't pay for their meds. They get kicked out of their apartments. They can't afford caregivers. I mean, we've seen people that have been made to be completely destitute that were otherwise, could have had a comfortable living. So what do? Well, the healthcare profession, we've been slow. Yeah, maybe screening won't harm people. That's what they said. In Texas, it's mandatory to report. Doctors don't report too many, but about a quarter of them come from other health professionals, mostly social workers. So here are some of the things that you might see. Patient says, I'm all alone, no one cares for me. Or they may say they hurt me, they may not. I don't know what happened to my money, they say. I just don't know what happened to it. My caregiver's too busy. And some of those things might be true, but I don't want to complain. My daughter yells. Self-neglect, I'm fine. I don't need you. Everything's fine. And I'm worried that the cats aren't going to have enough food. So APS are the ones that we must call. And we've alluded to that. We've talked about it. There's a hotline. You just write APS. You just Google that. It'll come right up. I've done the online thing. It's very, very easy. Or you can call. APS does all this stuff. They take reports. They're now a separate agency, and they report directly to the governor. Have you heard this? Yeah, they report directly to the governor now. They used to report to Health and Human Services. But, you know, this is investigations. We're looking at criminal behavior. And so it makes sense. And also it happens to be that the commissioner is a former Texas Ranger. So he comes from a criminal justice background. I mean, he followed up on on the deaths of elder abuse and child abuse victims, and he's come to the conclusion this has got to be investigation. Anyway, they work on capacity, they develop care plans. Any of you interning at APS? Any of you all doing any work over there? Well, you will have an opportunity to do that. Is that how it goes? And you get to go to the possum house and other places like this. So in there is a little possum. And it's, you know, rats and other small animals that we see. And that's what you get to do. You know, we're trying to send the medical students on these things. We're like, wear closed shoes, wear pants, you know, don't come in, you know, stilettos. Yes.
Do you find that the team approach that you were talking about earlier lessens the incidence of abuse, or do they not correlate at all to each other?
You know, in the studies that we've done, yeah, it did lessen abuse. Mostly in the, I think it was the caregiver neglect and the financial exploitation. We made more of an impact, but it does because the interventions. Sometimes you just need, the doctor's the only one who can say the patient lacks capacity. Because if they have capacity, your case isn't going anywhere. So you have to stop it, you know, whatever. If the person has capacity, they can allow their daughter to yell at them or their son to take their money, or vice versa. They have that right to do that. But if they lack capacity, then that's when all of us here, we all have to act. And so that's the difference. That's what that's what needs to be done. That's why you need the doctors involved.
I had a question about the last slide.
Yes.
So this was a question on the last slide where the house was a really big mess, and so I want to just know, what does it take for someone to let their home get to that point in their life?
What a great question. You know, how do you let it get like that? Nobody really knows. I think that some people they develop dementia and they just can no longer clean, or they're depressed and they don't have the get up and go to do what needs to be done, or they have psychiatric illness, or they drink, and then for periods of times they're impaired. You know, but you would think still the smell, you know, you can't smell on these slides, but the smell and the stench and all of that can be overwhelming. And so actually we had PhD researchers who would like to tell us how it all needs to take place. When we were doing the studies, we'd send them to the worst houses out there. I know, you know, I must confess we did that. You know, we were wanting to study people's brains with a functional MRI. So a functional MRI tells you how your brain reacts to it, and there's some thought that, and so what we want, the study we'd like to do, we haven't got it funded though, is to show people disgusting pictures and see if it triggers something in their brain or not. So maybe there's something functional in the brain and they can ignore it. But you know, even smells like that, right after a while the smells, you know, they extinguish. And so maybe it's something, it's just so bad, you can't do anything about it and you just learn to live with it. I don't know. That's a great question, a great research question, yes.
Whenever an elderly person doesn't have the capacity to clean up after themselves, they just learn to live with it. I was in Professor Goins' class, and she was talking about a patient that had roaches on him because he was just not able to do anything about it, and he didn't have anyone taking care of him. So they just have to live with that. They can't physically do anything.
Yeah, that's right. I mean, I think that's a good answer. Sometimes you adapt. So here are all the people on the team, you know, the psychiatrists, everybody that was on a geriatric assessment team. We just took that geriatric assessment team and said, well, maybe they could help elder abuse victims, elder mistreatment victims. We opened the Senior Justice Assessment Center. Angie talked about it. we've been planning this for many, many years, and I'll tell you that the cases we're seeing now, financial exploitation. Far and away the most common, because there's not good teams to deal with this. There is a financial abuse specialist team, but they don't prosecute cases. They give advice to families, etc. We now have the first in the country, it's here in Texas, telehealth communication system for the assessment of abuse and neglect elders. So they were doing it for children. And so now we got in the game. And so we've done 60 cases since July, where it would have taken us months and months and months to do 60 cases. All the data can be uploaded. We can interview the patient on the telehealth and telecommunication. And we're now, they are getting prosecutions out of this because they're the doctors now. Dr. Halfin is just a great proponent of this. And he's a JD and an MD. And next he's going to become an astronaut. I think he's also a pharmacist. But anyway, all true. But they're willing to say, yes, this is abuse or neglect. And a lot of doctors are not willing to do that. He is, because he's got all the data at his fingertips. They're already wanting to write this up. This is, again, you know what? This is a result of an interprofessional team work together. Had APS, had all the sheriff's department, had others not been willing to work, we couldn't get this off the ground. This is interprofessional teamwork that made this happen. So the last thing we're going to talk about this evening is what are the other things that this population needs. And I have a little caregiving quiz, but I think it's too long for this. Well, I tell you what. Why don't let somebody read these questions that people have you ever been in a caregiving situation? And think about this. Yes. So, would you each read a question here? Would you read the first question for us?
Had trouble keeping my mind on what I was doing.
So answer yes or no, right? That would be answer no. How about?
Struggle they couldn't leave my relative alone.
Had difficulty making decisions. Felt completely overwhelmed.
Okay. Can you read the next?
Felt useful and needed.
Felt lonely. Been upset that my relative has changed so much from his or her former self.
Felt a loss of privacy and or personal time.
Do we all have many left?
Been edgy or irritable.
Had sleepless drives and was caring for my relative.
How many people have ever had this happen? All of them. I mean, just look at this. Look at this. Caregivers. I mean, like I say, I shared the story of my family. You know, my mother, and I'm not even. Yeah, when I visit, I come back a complete wreck. This puts people in the hospital. It causes depression. There's another set of these, but I mean, we can look at them. Crying spells, felt strained, back pain, ill, been satisfied with the support my family has given me. How many people feel like they're alone in taking care of these? And I thought, I was never so happy to have siblings as now because, otherwise, anyway. So I think it's good for us to be cognizant of all of these things. It's the fastest growing occupation, formal caregivers, crazy. Now, driving. Should older people be allowed to drive? People are shaking their heads, huh? All right, well, there's going to be a lot more drivers that are elderly as that baby boomers come up, okay? By 2030, when all baby boomers are at least 65, they will be responsible for 25% of all fatal crashes. You all know what Katie's Law is? Katie's Law is a law in the state of Texas. This young lady was 17 years old. She was driving to school to take an algebra test, and an elderly person ran into her. And she died. And so in Texas, there's a provision that in-person driver license renewals in the state of Texas are required starting at age 79. And at age 85, renewals are required every 2 years. And they require a vision test for all persons renewed under the current statute. So if you're in criminal justice, you might be investigating some of these cases, etc. So how strict do you think the state of Texas is on this stuff? Not. My husband's legally blind. He has an eye disease, right? So he went in he just wanted his ID. He didn't want a driver's license. Well, they didn't have the IDs that day, so they just gave him a driver's license. Serious, I can't make this up. He's not going to drive, I mean, one time I brought a 100-year-old lady to the medical school class. And she's this tiny and I mean, just this big and darling. And she walked across the stage and she said, I'd done a little interview and I wanted her to walk for the people, and she was so great. And she says, Dr. Dyer, you don't know this. I just got my driver's license renewed today. 100 years old. She could not see over the steering wheel. I don't know how she got it. I wanted to, and I was like, oh, how wonderful, but anyway. Look, aging, it's not that I don't think people should drive, but the reaction times, the perception times, you can't process the information, the fatigue, forget the medicines, dementia. So one patient says, don't you think I can drive? And I said, well, move your neck side to side. And they went like this. Because the family said, should I let him drive? And I said, I don't know. Would you get in the car with, would you let him drive you around 610? I don't know. We really have no legal standing. There is this medical mobility, medical mobile association, MMA, part of the DPS. You write them, nothing happens. They throw that stuff in the garbage. They've never contacted. I've written names. They've never contacted people. Anyway, look at these numbers. Older people, I won't read them all to you, but you're more likely to die and have less miles driven if you're older and you're in a car wreck. So what can we really do? I think we all have to be aware of that. We all have to be aware of that. I mean, I think, it would be great if when elderly people got stopped there, at least we got some sort of mental status question to see what they're doing. How about driver education programs? How about if you do your physical trainer, how about doing driver assessments? In some states it's required, where we do test the cognition, test the range of motion. They have a simulator, car simulator at UT Health in the eye clinic over there to see if people can really, they really can drive or not. Anyway, just to end with a few things, look at, this is just of 2000. More and more older people, right at the top, are going to be living alone with a disability. And this is the heat map of Houston. I mean, just forget, whatever you're doing, if you focus it on older people, you're going to have plenty of work, because the places that are really the sort of the dark, you can see the darker reds, that's where all the older people, look at the sections of Houston that have older people in there. It doesn't even, Hunter Creek Village, all of those places, when places flood and all of that, look who's in these neighborhoods. Anything you want to do in your career, whether it be assisted living or criminal justice, social work, trainer, anything that you want to do, you focus on elderly people, you are going to have a career for the rest of your life. This map tells it all. And then, of course, you could be involved in social activities with older people. And how much fun is that? What if you, like the trainers and all? So this was a medical school class at Baylor many years ago, looking at without gray hair. But so the 4 senior adults in that group, the 3 women were hula dancers. They were Pualani dancers, and they would come and they would do long, elaborate, dances for the medical students. And then that's Mr. Goins right there. Senior moments happen. That's Mr. Goins, and he would come and he would talk to the group, and he would do line dancing with the teacher, if she was cute. And anyway, and so, he was, it was really terrific. But there's so many opportunities for socialization for seniors. And I did not think that seniors would be volunteering in any group except children. I would go speak to these retiree groups or the 50th graduating class at Bel Air High School, and I asked them what they did in their leisure. They volunteer with other seniors. Yeah, so if you were somebody that helped organize that you set this up, or the training, education, driving, physical therapy, anything, there's so much need here. Anything you want to do in the aging population, you're going to have great opportunities. So we have to be prepared for what's coming down the pike. We prepare, in our own careers, in our own life, we can prepare. But if we get ready for this elderly population that we're going to be having here in Houston and around the country, we're going to do well, and we'll be able to meet the needs for the health care, for the criminal justice system, for any public service. And so this was actually a little lady from Katrina. And we worked on an interprofessional team with all the aging agencies, APS, Sheltering, several of them, and we put together a team that went through the Astrodome and helped to get people who were alone, get them into some care, either into a facility if they needed it, or to get them social services, etc. So we got to, we weren't prepared then for the amount of seniors that we saw during Katrina, and we ain't prepared for the amount that's coming down, but you guys are the hope that we can be prepared as a community and a society for older adults. So that's my last slide, and I've loved speaking to you. Thank you. And I ended on time. That's I did not want to keep you too late. So anybody have
revolutionized some new programs that weren't happening before, such as I think the geriatric assessment teams.
Mm-hmm.
How do we go? I want to be an advocate for people in nursing homes. How do we go about making changes in the current situation of our nursing homes? Anyone who knows me knows I have a love-hate relationship with nursing homes, mostly hate. And so there's a lot of deceit going on in nursing homes. There's a lot of neglect going on in nursing homes, and you think your loved one is getting good care there, and they're not. My mom was in 3. I had problems with all 3. I have a very dear friend whose mom was in 4. She had the same problems in 4. And there's so much that needs to be done in these nursing homes how do we go about starting that change?
I think that there's ombudsman programs, and the state has an advocacy, has groups that you could work with in aging, etc. There's a council on nursing home administrators. I think I would approach the area agency on aging at first, and I'd like to think about them more because there's so many avenues. I think it's such a big elephant that you have to eat it a bite at a time. So if you would pick one aspect of it, one group to work with, and then study that, then you can see. And then there are people that work on nationally. I would look at the National Center on Elder Abuse, see who's working on nursing home abuse, and maybe call some of them up and look at some of their papers and see. And that's where I would start. All right, you all have a great evening. All right, best of luck in your career.
On behalf of the College of Public Service.
How beautiful! Oh, thank you. Oh, isn't that lovely? Thank you very much. I will hang that up.
You can never have too many of those.
Oh, that's good. Thank you. All right. Thank you very much. Thanks. Thanks. Oh, it's okay. Ta-da. Thank you. Yay! It's beautiful. That's just beautiful. Thank you. Very special. Very special.